It's Friday afternoon, time for Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live. This program is also available on CTV3 in Connorsville. My name is Eric Marsh. I'm Executive Director of Whitewater Community Television, and as always, very happy to be joined by the people for whom the show is named, the doctors. Dr. David Jetmore, Wayne County Health Department, Dr. Thomas Huth, Reed Health. Gentlemen, thank you very much for giving us another hour of your week.
Our pleasure. Thanks for having us, Eric.
As usual, let's start with what you've learned new, what you've figured out, what you've seen. Dr. Jetmore, let's start with you.
Well, I think the big impression this week is I'm glad that I live in Wayne County, Indiana, because the coronavirus is increasing in 30 other states, chiefly those states to the southern and western states. I think the big ones are California, Arizona, Florida, and Texas. In fact, Texas and Florida are slowing their reopening process because of this increase in cases. On the other hand, Indiana has held steady or slightly declined, and Wayne County has continued to improve with a decrease in reported cases and a decrease in deaths. We've had 6 deaths since this began and none since May the 7th, so we're very happy about that, but I feel nervous about the future. I'm probably speaking for Tom as well, because we're opening up this to save our economy, and so that businesses can survive and people can work and bring home a paycheck. But we're trying to thread the needle between opening these businesses and being safe. Mm-hmm. And I'll end my opening statement by saying it continues to be very important that people, especially when they're indoors, distance themselves, practice good hand hygiene, and use face masks.
Well, you were mentioning Texas and Florida, pausing what's going on. I was kind of going through some things a little while ago. I think they are both, at least one of them, I think, are reclosing their bars. One may be keeping the bars open, but not allowing them to serve alcohol. So I'm not sure why you'd keep a bar open in that instance. But they are finding that, and maybe you two can talk about what you've seen. They're finding that it's young people who seem to be having the greatest problem at this moment, social distancing, particularly when they're out for an evening.
Well, I think it's the nature of young people to gather. It's the summer. You're young and free and full of life, and you want to be around other people, and I think it's more difficult for them to distance. Some of them may think that this is just a disease that affects older people, but we're seeing a lot of 20, 30, and 40-year-old people getting this disease. And this is not like having the flu and getting over it. Many of these people have lifelong sequelae from getting infected. They may have permanent damage to their lungs, their hearts, maybe a permanent loss of smell, which of course affects their sense of taste, and just the devastation of having the disease. It's not a fun disease to have.
Okay. Dr. Who?
Well, I think Dr. Jetmore summarized the situation very well. The increase in cases worldwide and in the U.S. is sort of the topic of the moment. And you mentioned that in the states where the increases are greatest are actually noticing that they're having many more cases in younger age groups, which is, perhaps a blessing and a curse. I mean, we do know that the younger folks tend to have less severe disease, less severe acute disease, and have a lower risk of death. That doesn't mean they don't have any risk of severe disease and death, and several places, particularly the larger counties in Texas and Florida that happen to be associated with the biggest cities, are seeing more hospitalizations and more ICU use. And I think it's too early to get all the statistics. We don't know much about the internals of that. Well, what are the age ranges and what are the complications that are being seen, but it is a concern. I saw one speculation this morning, somebody who studies it, interviewed on a national news program, who said that he thinks there's a possibility that it's the warmer weather. Now, that's just kind of the flip side of what we normally associate with COVID. We think that being outside in the warmer weather is good, and that's true. And Dr. Jetmore is a big advocate of people getting outside and getting fresh air and exposure to the sun a little bit and that kind of thing. But what this person was saying was that what needs to be looked at is in the Sun Belt states where it gets very hot, people actually spend more time indoors in the air conditioning.
Mm-hmm.
And so, maybe we're actually having this sort of paradoxical aggregation or congregation of people that could be driving some of their cases. And I think that's an intriguing thought, but I don't know that there's any data behind that, and that's something I'll be looking for.
Okay. As we have over the last few weeks here on Ask the Doctors, we try to bring someone into the conversation. This week, Dr. Anuradha Bhandari, who we have spoken to in the past. She was running the Respiratory Clinic. We have her, I think, on Zoom, and we can bring her into this conversation.
Good afternoon.
We don't, but we do have her on the phone. Yes. Good afternoon, Dr. Bhandari. How are you?
I'm great. How's everyone doing?
So far, so good. I'm gonna step out of this and let the doctors kind of step into this.
Well, Anu, thank you for being on the phone today. I thought it might be fun to have a chat with you since you were there you are on Zoom. That's fantastic. Since you were sort of the mastermind behind the Respiratory Clinic, and that really was a very good thing for the community and for the health system. So I thought it'd be great to talk about that a little bit. But I want to start actually with asking you, how has COVID-19 affected you in your practice? Because you actually have another life besides the Respiratory Clinic. You have a private practice, plus you do the perioperative clinic. What's your experience been with those two practices during particularly the lockdown portion of the COVID-19 pandemic?
Sure. So we've seen, and thank you for having me, Dr. Huth. We've seen a evolution in kind of how things have happened over the time when we first became very concerned and had our lockdown, and to where we are now. And I think initially, like many places in the country, we had to decide what would be sort of a safe way. We leveraged telehealth during that time. We were able to kind of centralize our care, and I think the reason for how the Respiratory Clinic actually came up in my mind was, as things unfolded in the country, I began to think, well, how am I going to care for my patients in my community as an ambulatory outpatient physician? And that's where the thought came to look at creating a centralized pathway where I would be able to send patients that have respiratory symptoms to one central location, and that the rest of the ambulatory practices, my perioperative practice, my primary care practice, could continue to function the way that it is. So if a patient has respiratory symptoms, we would refer them to the respiratory clinic, or if they had mild symptoms or were not feeling like they could come into the office, we offered telehealth. And slowly over time now, as we've created that, we now have a safe pathway in which we're able to kind of bring patients back into the office. I think now we want to send out the message that full spectrum care is back, all of the diagnostic testing, the office visits. So initially, yes, we had to think up of what would be the way that we would be able to offer care, and we used those various methods, and now we're kind of back to having our open practices.
Well, that was a genius thought about trying to take the COVID-19 patients or people with respiratory illness and have them evaluated on a track that doesn't put them with other non-respiratory patients and therefore increase the risk of spread. We took that, put it onto a separate track, and I think that was really good thought. So that's the theory, but what actually happened in practice? What do you see as some of the benefits and results of the respiratory clinic?
So in the respiratory clinic itself, we were able to have patients call in a hotline or read Health Now, and they're able to be screened and their symptoms or exposure was discussed. We then allowed patients to kind of drive up, and we had drive up evaluation initially. So patients would drive up and be evaluated by a provider. They would then be, once testing was available, would be tested there at the respiratory clinic. If they felt that we needed a more extensive evaluation, the patients, we removed the waiting room, and the waiting room was the parking lot. Patients were brought in to a room directly. Everyone was in full PPE, and that continues to be the case at the respiratory clinic, which now we have the urgent care together, and are evaluated in the room. That allowed us to see 5,000 patients through the Read Health Now or screening call. Over 3,000 visits happened as of early June, and 2,200 patients were examined in the respiratory clinic. 5% of those patients went to the emergency room, and about half of those patients were admitted. So what that tells us is that we were able to manage a lot of the patients within the community in a centralized way, protecting the rest of the community, and allow them to go home with remote monitoring. We were monitoring those patients for 14 days, and that led to low exposure in the emergency room, so that those patients that were particularly severely ill were able to be managed without burdening the entire sort of healthcare system in our community.
Well, that's great. Now, things have changed all the time over the course of the pandemic, and that's certainly true with the respiratory clinic. So what's the future of the respiratory clinic, Anu? What do you think it's going to be doing in the next month or 2 or 3 or 6 months from now?
So I think we are going to monitor, and we hope that we continue on this positive trend within our community. But all of, my favorite phrase is we have the playbook, and we have put that kind of on the side as we try to open up our community. The respiratory clinic is still available. Because of the low volumes in our community, we've brought the urgent care and respiratory clinic back into the original urgent care building. However, we've maintained our centralized process. So that means that patients that have respiratory symptoms are seen there, but are in the waiting room of their vehicles, so to speak, and are brought back into rooms that are dedicated for respiratory symptoms. And then those patients with non-respiratory symptoms are being seen in the urgent care and have the waiting room. Of course, everyone is still wearing masks and maintaining social distancing. We do have appropriate PPE and frequent cleaning and washing. And then the future will be, we will cross our fingers and see what happens within the community. Heaven forbid we're in a situation where we need to go back to the process that we had before. I think we've worked out a healthy and good process, a safe process for our community. So we will go back to that sort of operations.
So a little bit earlier, Anu, you referred to the fact that we're getting back on track with routine services. You've basically turned the respiratory clinic activities mainly over to others to manage on a continuing basis, and you're concentrating back on the perioperative clinic as we've gotten surgeries going again, and also your own practice at Read Medical Associates. What are some of the things that the Read Health system is doing and that you're doing in your practice to make it safe for people to come get services again?
So we mirrored the same process that we had in the respiratory clinic to what we are doing in our ambulatory or outpatient practices across the board. So the whole vision was to allow practices to fully flourish and function as they are. So now we use the same process. A patient will call in, they are screened by phone for symptoms. If they have respiratory symptoms, they are then asked to go to the respiratory clinic and are referred there, or if their symptoms are mild, they are then seen through telehealth. If it's a routine visit and they have no symptoms, they are waiting in their vehicle. They're then asked to be brought in, and my staff member is waiting to welcome them. They receive a mask, their temperature is taken, their symptoms are screened, and then there is no waiting room. They're brought directly into a room where I'm awaiting them, and I'm able to do a full evaluation for them. We have a routine visit like we have been. They have their diagnostic testing if they need to, that being labs, x-rays, etc., with their masks on. Once the patient has completed their evaluation, There's no checkout process. They kind of head on their way. Everything is done in advance by phone, and their appointment is set one after they've left. They get a phone call. I also have telehealth available, so I stagger my appointments to allow that we aren't overburdening that process in which patients come in. So whatever the patient prefers, we're able to accommodate that process. I should say, though, that I want to emphasize that I have told all of my patients it is safe to return back. I think there was a misunderstanding very early on in this process. Many of our services were shut down in order to develop what would our plan be and how would our pathways be. That has all been designed and is created now. So I'm really encouraging folks to get back into their practices, because we're fully open and offering our full spectrum of care with all of these frequent processes. Every time I'm done seeing a patient, I wipe down the room, I sanitize and clean, my staff does, and then we bring in the next patient from their waiting room, which is the vehicle.
Well, Dr. Bhandari, this is Dr. Jetmore. I don't have any further questions, but I have to give you a virtual high five for that respiratory clinic. But because before that respiratory clinic was in place, we were running around like chickens with our heads cut off. Patients didn't know where to go. Their doctors didn't know what to do with the patients that were symptomatic. They didn't want them to come to their office and contaminate their office or other patients. And that satisfied an incredible need, so good on you.
It was my pleasure. I think I can't take the credit. I had a wonderful team that, I should say that from the moment we thought of this idea, Dr. Huth looked at me and said, "You got 48 hours. And we really, within 48 hours, had a huge team. Every barrier by our administration was removed. A lot of hard work from many people in many levels of the organization. So I am very grateful to all of them, and this is their success. But I will tell you, the feedback that I've received from the patients and the community has been nothing but positive. We had an opportunity to kind of really lower the anxiety, I think, in the community, offer a lot of education, comfort, testing, everything in sort of a one-stop shop place, and allow all of the practices within our community to fully function the way that they were, protecting both patients and staff. So it was really a wonderful experience. I don't think any of us had ever been a part of something like that. To bring the community, to bring all of the employees together to serve the community that way was a great honor.
Well, Anu, thank you so much for being with us today. I'm going to let you get back to your routine activities, your important things with your patients. We've kept you a little bit longer than we anticipated, but it's been great speaking with you. Thanks for spending the time.
Thank you.
Thank you, Dr. Bhandari. Some of the things that she mentioned, maybe before we get to a couple of questions, maybe you all can talk to. Some of what the processes that your offices are going through, how much will that help advance medicine and how doctors are able to more effectively and efficiently take care of patients? You know, you always get this feeling, you've gotten this feeling in the past of people showing up for doctor's appointments, sitting in a waiting room, waiting longer than they anticipate. Things seem to be moving along a bit more crisply now. People aren't sitting in waiting rooms. They may be sitting in their cars for a little while, but has some of this made medicine more efficient, made people think about time, think about scheduling and that type of thing a little bit more?
Well, that's a really good question, insightful one, and I think the answer is yes. I think that we're going to see some things changed in the way that medicine is carried out, executed, you might say, that won't go back to the old way. You know, that we're going to use lots more technology, telehealth as an example. All of our practices are continuing to emphasize using telehealth where that's possible. Now, the telehealth, what we have learned through the process is that we can't do everything by telehealth. Mm-hmm. We've been kind of making do with it in some situations, but there are other situations where we just need more hands-on. Question is, how much can you actually substitute by technological means? And so we're getting ready to make more investments in a higher, more technology to support telehealth, like electronic stethoscopes and other things that can still enable a better examination remotely than what can be done over the standard apps today. And so those kinds of things we're going to see more development on. But I think some of the things related to the way the office practice flow happens are going to stay as well. I went to the eye doctor, just to have my regular eye checkup just a few days ago, and wherever I go, I'm asking other people, what do you see? How's this experience been for you? What do you see staying? And what the doctor told me was that it was a little bit challenging at first just to figure out how to organize it, but now it runs as smoothly as a normal office day does, and they're just going to keep doing it indefinitely. They're not worried about going back to the old ways of practicing. So the things that Dr. Bhandari talked about, waiting in the car, sort of checking in virtually, and that kind of thing will go on, I think, in most practices. But there's an underlying fundamental aspect to the question that you asked, Eric, that I think is worth calling out. I notice a certain parallel with a prior experience of mine, and I think anybody who's been on that track that I was on once in a former life when I was in the Army and was deployed to a field hospital supporting the 101st Airborne Division in the first Gulf War, 1990. The experience of mobilizing for a war where things happen a whole lot more quickly than they would under normal conditions. Mm-hmm. And what happens with that is that people experience that. They experience working with larger teams to get things done. They realize that they can actually come up with effective systems on the fly and improve them on the fly, make them very high performing in a short period of time under adverse conditions. And I think a lot of my colleagues on the Reed medical staff have not been through that, and so they didn't know that they could do that. But now that they've had that experience, they now have the confidence that should we have significant resurgence and have to take steps, we are prepared. There's a lot more confidence, I guess, is what it boils down to, about how to handle the future. We have more confidence that we can not only handle people's routine medical problems and checkups and surgeries and so forth, but also deal with the COVID patients. We didn't have that confidence early on, but now we have it. Dr. Bhandari referred to having the playbook. We know what to do. It's all documented in diagrams and policies and planning materials sitting on a shelf now, so that if we need to re-implement those, we can do it much more quickly and confidently than we ever could in the past. And I think you have to have been through that experience once to realize that that's what you can do. So we have a lot more confidence now as a system. I always knew it was there because I've been through that before. Mm-hmm. Not everybody has that experience, but now we all do, and so we're ready to, on a moment's notice, being able to spool up the things that took us a few weeks to do. We can do in a matter of days now.
You've seen it. You've seen it for a number of years in your practice and watching other doctors. Are there things that you've seen kind of step forward during this that you think are positives, not only for the folks in the medical profession, but for those of us that end up being patients?
Well, I think, and Tom mentioned this, and of course he's spot on, is that the technological reliance that we've had. I mean, telehealth in medicine has been around for a while, but it's been very slow growing. We've been kind of forced to rely on it in this pandemic, and I don't think that will go away. It will continue to grow. In fact, I think it will affect all of society. I think a lot of companies have commented that their workers are just as efficient working from home electronically as they would be if they came into an office. Mm-hmm. I think telehealth is limited in some aspects. I think somebody with an unknown disease presenting that needs a physical exam, but there's a myriad of uses for it in a physician's practice. Follow-up visits for chronic disease comes to mind, where it's not really necessary for a thorough physical exam, history, vital signs, and just seeing how the patient's doing will be sufficient, and it'll be good for the patients. Waiting rooms will be less crowded. You'll be able to sit in your kitchen and have your checkup, and the doctor will call in your medicine, and you'll continue on. I think all of this is good, and it's kind of been forced on us, but it's been a good thing.
Part of it was, and nobody's picking on the government, but part of this was the government wasn't allowing some parts of telehealth to advance. Is that a correct statement?
You're right about that. The government, prior to COVID-19, was kind of two minds, all at the same time, that were somewhat contradictory. They wanted there to be more telehealth, but they had a lot of restrictions around it that really minimized the ability to expand it rapidly. Like you could only use it under certain circumstances. You could only use certain types of technology associated with it. But actually, an important step that that CMS, the Center for Medicare and Medicaid Services, took early on in the pandemic was they issued what are called 1135 waivers, and 1135 refers to the U.S. Code section that gives them the ability under emergency conditions to remove certain requirements on a temporary basis. And so we refer to those as the 1135 waivers. And the waivers were very concentrated on the barriers to implementing telehealth for the pandemic. And so we expanded the ability to use a larger number of platforms for telehealth technology. Some of us are using a product called Doxy.me that doesn't have all of the components that CMS would normally regard as being necessary for the right platform, but they removed all that. That's just, and they expanded the code sets that we can use for the billing piece. Did all that very rapidly. So those are just a couple of examples of the many restrictions that the 1135 waivers removed, and really ramped up suddenly the use of technology around the country. And our use of telehealth expanded by 10 or 15 fold over what it was prior to the onset of the crisis. And what we're interested in now is what happens when the emergency is over. How many of the 1135 waivers are going to remain? Mm-hmm. How many are going to be rescinded and go back to the old regime? And how many of the permanent restrictions, or the permanent requirements will be changed to encourage the use of telehealth going forward? And the administrator for CMS, blanket on her name, Verma, forgotten her last name, but she actually was a senior advisor to Pence when he was governor of Indiana during the implementation of ACA, but she's now the CMS administrator, and she has said publicly that there's no going back, that telehealth must continue. So I think we're looking forward to CMS changing some of the permanent regulation around telehealth to enable more of it to go forward, much like it is right now, but there'll probably be some changes. And we're implementing changes. Looking forward to that. I mentioned that we're going to be investing in more technology. We're going to send nurses out to nursing homes to actually be the eyes and ears of the doctor on that end, so that we don't either have to bring the patients out, we don't have to send the doctors in, but we'll send nurses there to work that end of the telehealth connection and actually work the electronic stethoscopes and so forth, the electronic pieces that will be available there. And that's an example of the kind of thing that I think we're going to see going forward. For as long as COVID-19 is an issue at all, long-term care facilities are going to be are going to have significant restrictions. And so we're trying to lean into how to be prepared to take care of those patients better. And so that'll enable our specialists our cardiologists to have their visits with the heart patients and so forth, without bringing people out of the facility, which increases the risk to them. And so we're looking forward to positive changes in the telehealth front going forward.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live. This is really about your questions. I suppose I've asked a couple of my own, but let's start to get to your questions on this show. Can you talk about the information or results from the random testing that has been gathered by the State Health Department and the IU School of Public Health? Are the findings of the study considered good news for Wayne County residents?
So this question is actually a really good one, and I think Ryan said to us beforehand, this actually came in last week, but it just happens that I brought today some excerpts from the weekly provider webinar that the State Department had, Indiana State Department of Health has, and Ryan, if you can show those, you can see the first one there. Basically what they reported recently was the sort of preliminary results of the second phase of the Fairbanks School of Public Health random testing around the state to try to get an understanding of how prevalent the disease is in the communities. And back on that first page there, Ryan, we can see that in phase one, the active infections, which is the nasal swab test that detects the genetic material of active virus in the nose, that was, in their random test, 1.7% of people were positive on that test. On the blood test, the antibody test indicating infection sometime prior, that was 1.1%. When you add that up, you get 2.8%. That was prevalence like it back in April or early May. Now we have the results of phase two, which was conducted in early June, and I will say that to me the results are a little bit disappointing. I was hoping for a much more increase, but the active infections were down to 0.6% of the random tests. I guess that's good, but the positive antibodies only increased to 1.5%. When you add that together, that's 2.1%. So that's actually overall a decrease in prevalence if you just go by those numbers. Now, the caveat to all this is that, this is intended to be a truly scientific study, and they're going to publish these things later on at some point. And so what's missing informationally from these preliminary results is any assessment of the confidence intervals around that. When you do sampling, and you come up with numbers 0.6 and 1.5, but in actuality, the confidence that the numbers are within a certain range around those numbers. I think what it's going to boil down to is that that there probably isn't a significant change in prevalence in that time, and if there is a significant change, it will be fairly minimal, maybe up a little bit. Now, to me, that's a little bit disappointing. I was hoping that by now we'd have a lot more prevalence in the community. And so those who think that we should be emphasizing people get out there and get infected and get over it and develop herd immunity, we are far, far, far away from the levels needed for herd immunity and don't seem to have made a lot of progress in that direction in my assessment of the data totally. Now, Dr. Jetmore might have a difference of opinion. You may be looking at it from a different perspective.
Well, the one dilemma with herd immunity, which most epidemiologists call 60 to 70% of people having had the infection, is we still don't know what it means to have these antibodies. We don't know, there are many anecdotal reports of people having this disease and then getting it a second time, which suggests that the antibodies they had were not high enough to protect them from a second infection. So we don't know, we see people with antibodies to COVID, but we don't know what it means. With flu, it would tend to mean being immune to the disease for 10 or 12 months. But with COVID, we don't know. It may only give us, it may be a weak immune response. We may only be immune for a couple months. If that's the case, we probably won't reach herd immunity in in the practical sense, and I think once again we're going to be waiting for a vaccine to be developed. And vaccines always, or almost always, are superior to the vaccines excite such a strong antibody response that your immunity is much stronger even than having had the disease itself. So, and unfortunately, I mean, everybody wants this vaccine by next weekend, but everything I see written by virologists or epidemiologists suggests that it's not going to be until spring of 2021 that we see a vaccine.
Right.
You heard this week that China was working on something, and there was some conversation that they might see something by the end of the year. Are you all, from what you've seen on the research on that, are you kind of saying that end of the year thing may be more hope than realistic?
Well, I think you're always hopeful. I think, I jumped in there, I'll let Tom speak as well. I think you're always hopeful, but you know, we've got the greatest minds in the world working on this problem in various labs all over the world. The dilemma is there are many different kinds of vaccines, and it's not difficult to create the vaccine. The devil's in the details, in that we have to make sure that the vaccine is safe, that there are no side effects, that there are no permanent injuries to the person getting the vaccine. How long is the immunity that the vaccine excites? So, you know, the first vaccines out of the box may not be the vaccine that we're looking for. It may be better than nothing, but it may not be we're looking for a silver bullet here. And we may not have that the first time out of the box. What are your thoughts, Tom?
Yeah, I agree with that. I think that there are a couple of things that should maybe temper our enthusiasm a little bit. And those are that there has never been successfully made a coronavirus vaccine before to any of the other coronaviruses. It's been tried for ones that cause common cold. It's been tried for SARS, it's been tried for MERS, and just not much progress in that area. Now, there could be, maybe this will be different, and that's what we would hope for. Then the other part is just the pace of development. I mean, you have to realize that normally it takes several years to develop a vaccine, and that's when everybody's working really hard on it. We're talking about marshaling resources to develop that level of vaccine that Dr. Jetmar referred to in 6 months. And, you know, I hope they do it, but it will be an amazing scientific achievement worthy of somebody getting a Nobel Prize if that happens. And, and maybe it will, and I sure hope it does. But there's also a difference between when it's, deemed to be safe and effective and ready for general use and actually making it generally available. We see with the testing, as an example, early on in the whole thing, before it was even a significant problem in the United States, there were tests for COVID-19. But you can see that it's taken so long, months really, to get testing available generally, and we're only right now able to make it generally available to anybody who wants it. So, the timing and all of this says to me that even if they make this remarkable technological achievement come true by the end of this year, it'll be 3-6 months after that before there really is a vaccine in this community ready for everybody generally to get. And I think that's the optimistic version of things, and it could be a lot longer than that.
I think we're more likely to see progress in a treatment than we are in a vaccine. And we've seen this to some degree with remdesivir and with using steroids to treat people that are in the throes of COVID-19 on a respirator and very, very sick. So the challenges to a treatment are not nearly as formidable as they are to creating a vaccine. But like Tom said, I hope that they are able to win that Nobel Prize and come up with that vaccine.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11. Dr. David Jetmore, Wayne County Health Department, Dr. Thomas Huth, Reed Health. Next question up. If the CDC has approved both the posterior nasal, help me out, gentlemen.
Nasopharyngeal.
Nasopharyngeal. Thank you. I got it before we went on the
You
air.
nailed it,
Testing and the anterior nasopharyngeal testing to have the same reliability rate for COVID. What test is Reed using for patients undergoing surgery? And if the anterior is acceptable, can a patient use the free testing site instead of being tested at Reed as part of the Preop, which goes through billing?
So there's a couple questions in there. One is, what test is Reed using? We're using the standard posterior nasopharyngeal swab. It's the least comfortable version, but it's what our technology is set up to do. The anterior nasal swab can certainly be done and would be acceptable to us. And in fact, having the test done at the Optum site is acceptable to our team for pre-op testing. But I think that the important thing to note is that from the time that you get the test prior to surgery, you have to quarantine. So regardless of where and how you get the test, you have to quarantine. And of course, that test result needs to be available to our caregivers and not just a verbal report from the patient. It needs to be an actual printed test result for them to make a part of the medical record. So absolutely, people could go to the Optum site at the old Elder Bierman site. But there will be some nuances around that, so I think it will be worth coordinating with the doctor's office to make sure that the testing is done at an appropriate moment, that we do get the quarantine, and that the result is available prior to surgery.
Okay. Next question. As these nurses go into nursing homes, somebody's following up on your
Yes,
statement.
that's great.
Will they be required to have baseline testing as the routine staff are?
The answer to that question is yes. So not only that, they're also going to be doing symptom monitoring and temperature checking in addition to periodic testing.
Okay. So we have another one. Colleagues have taken colleges, have taken out fall breaks to shorten their semesters and prevent traveling midterm where students could leave and bring back illness. Do doctors have any thoughts on that for public schools?
Well, the thing with local public schools is, these college students live elsewhere. So they're traveling to college from other states often, or distant parts of the states where the college is. So that's where the concern is with traveling. I think that IU, and I'm not sure about Purdue's plan, but IU plans to start in the fall, shorten the fall semester, and then during the winter months there'll be e-learning, and then school will resume in person in the spring of the year. But I don't think there's a plan for that in the local public schools. We do have a plan. We've talked to the commissioners. Our current goals in educating our public school students is social distancing and masking, and hand hygiene, which are really the only tools we have, and carrying on as best we can. I think the risk to the young students is probably minimal. As Dr. Huth says many times, not always the case, but in almost all cases, COVID in the very young is maybe as slight as no symptoms or a headache for a day or two. The main people that are at risk in the school system are the adults, the teachers, the school custodian, the school nurse, the bus drivers. One of the things that I think we will do that I think is unique is we want to have the children assigned to a certain seat in the classroom or a certain seat on the school bus. So if there is a positive case, it will be easier to trace the contacts from that particular student. We'll be able to tell where that student was during the day. It'll be easier to trace any outbreaks of the disease by keeping these children in, or these groups of students in cohorts.
You all can't, or maybe you can, mandate what you just suggested, but you can suggest strongly what is the health department's place. And I know that you all had a couple of weeks ago, and we're still airing the health department meeting, where you all had the superintendents in conversation. I think those conversations do continue. Hopefully we'll have more superintendents as we go through these next few weeks, along with representatives from some of our local colleges. But what is it that you all are, how strongly, I guess I should ask, can you all actually suggest that some of these things happen?
Well, we do have the ultimate power. I mean, we can shut down the school. If things aren't going the way we want them to, we can end it all. But having said that, we're not signing off on their plan. The school is the superintendents are putting together a plan for the school with our input, which is trying to be a cooperative input between the health department and the schools to create an environment that is safe for students and teachers and all of the adults in the school. Now, having said that, all of us have dealt with young children. All of us were young children. You know, social distancing becomes problematic. Wearing a mask becomes problematic. However, we're weighing one thing against another. I think it would be catastrophic for these children not to attend school for a year. And that's what it would mean if we decided that it wouldn't be safe. On the other hand, I think, will it be do we have a perfect solution? No, we don't. But there are many things we can do. We can space children out on school buses, for instance. We can encourage some parents to bring their children to school to lighten the load in the school buses. We can have traffic going just one way on each side of a hallway. We can discourage things where people are brought together, gathered together. They're brought to one place. You know, Eric, I think just educating a bunch of young children is basically an impossible task in a non-pandemic situation. Now we're asking these teachers to put masks on these children and physically distance them and then teach them. And it will be very difficult. I have nothing but admiration and respect for our teachers. But these teachers are very dedicated people, and they'll do the best they can with these parameters to get through the situation and for the children to have a good and educational school year. We'll be there to answer any questions they have. Obviously, they're going to look to us if there's an outbreak. How do they handle that? Who should be sent home? By having these children in cohorts, we hope not to shut down an entire school system. It might be a classroom. It depends on how small you can make these cohorts of students. But that's our plan. And we're continuing to meet with the school people.
Ask the Doctors, Whitewater Community Television, WGTV Channel 11. We do this every week. Next week, I can tell you, we will be recorded. It is kind of heading into the 4th of July weekend, and we're going to give Ryan and Steve and Michelle and the rest of the staff kind of a next Friday off. So we will be here at 2 o'clock, but it will be a recorded conversation, and I think it'll be incredibly interesting. We are still taking your questions. You can send us a question via Facebook, or you can send us a question on Twitter at WCTV Info. Where can I get and how much does the antibody test cost?
So you can get it You can get the antibody test at least a couple places that I know of, and there may be more outside of this county, but in the county, you can get it at Reed. Right now, at the moment, it still requires a doctor's order, but we're looking at ways to make it available like on a self-scheduled or self-referred basis. I'd hope that we'd have that available already, but there are some challenges with that, just to sort of some of the behind-the-scenes technical components of that, but that will be available soon. The cost is going to be $65. That is that's going to be the price of it. That is competitive with what we know that other organizations are providing it. The other place I know of in the county where you can get it is at the First Care Urgent Care on the east side of the city. I don't know how they arrange it. I know that they'll submit insurance, and I know that their price is also around that, is what I was told. Don't know for a fact, but how much at the end of the day each patient's going to be left with after insurance and so forth, I'm not sure. It shouldn't be very much, because a part of the requirement from the federal government is that insurance plans have to cover it.
Another question? I think we just did that one. Okay. How is Wayne County doing the testing, contact tracing, and treating of people with COVID-19?
Well, Wayne County itself is not doing, the testing we do is done through other means. I mean, it's done by Reed Hospital. People can get this test at CVS. They can get the test at the old Elder Bierman site for free. If we find that someone has COVID, we have contact tracers. And these people, our contact tracers, contact the person who's positive. And we try, as the name implies, we try to find out what contacts they've had, where are the places they more commonly go, to see if we can find an origin for this. What pharmacy do they use? What drugstore do they use? What church do they attend? Now that the bars are open, it may be what bars do they frequent? Because we can match this up with other positive cases and see if something served as kind of a trigger event. The patients are asked to isolate, to self-isolate, and to try to keep apart from other family members. I think probably the other family members are the most at risk. They're harder to keep away from a COVID-positive patient. But these are methods that have been used to trace infectious disease, whether it's a venereal disease, whether it's tuberculosis. These have been used for 100 years or more by public health officials. And these are the methods we use to try to trace down positive COVID patients. As you can see, as these numbers get greater, the number of contact tracers, the need for that is going to become astronomical. I mean, some people estimate it'll take a couple 100,000 people to try to ferret out where the disease originated. This disease has an RT, which is a number, which means what's the average number that a person infects if they have the disease. It can be anywhere from 1 to 3. But if you infect 3 people, you can see how this grows exponentially. 1, 3, 9, 27. I can't do the next math, but you can see how large that number grows. But we're going to need these people in order to corral this disease.
Before we get out, I know, Dr. Huth, you update us every week on where the numbers are.
Yes.
At Reed. Why don't we do that real quickly? We've
Sure.
got just under 4 minutes to go.
Okay. If you want to show that, Ryan.
If you've got that slide up.
There we go. This should look very familiar. I've added a couple of elements. The last bar on the right is the most recent data. And again, just a refresher, this is a weekly aggregation of average daily counts in three categories. The tall bar is patients in isolation beds at Reed. The lower medium bar, middle bar is numbers of laboratory positive cases in the hospital. There are various reasons why that's not the same as the tall bar. Then the lower number is number of patients on ventilator. So in a sense, it kind of gives you a graded sort of severity scale of patients. You know, how many are in the hospital, how many are known to be positive, how many are on ventilators. And I added the trend lines, and I added the dotted line as a longer-term trend line. You can see that still is in the downward direction for the total cases in hospital isolation beds. I also added a trend line at the bottom for these cases in the ICU on ventilator and lab positives. To me, the long-term trend is down, but basically we're at a plateau level for several weeks on the more severe indicators. So to me, what that means is, you know, I'm sort of cautious. I come out of this sort of cautiously optimistic. This isn't going away anytime soon, I don't think. We're always going to have that background of sick people who are in the hospital. But I think that maybe the overall numbers will be down, but the sicker cases may be at a plateau level to go on for some indefinite period of time.
Okay. We're going to wrap up the show there. I want to thank our doctors, Dr. David Jetmore, Wayne County Health Department, Dr. Thomas Huth, Reed Health. We'll be back with you again next week with a recorded program, but should be informative. We do want to remind you that free COVID testing is still available. That is 8 a.m. to 8 p.m. at the former Elder Bierman building, LHIcareforward/COVIDtesting.com if you need more information. This has been a stressful time. BeWellIndiana.com is there to definitely help us out, adults as well as kids. BeWellIndiana.com. We want you to get out. We want you to eat well. The Richmond Farmers Market is a place where you can do that every Saturday, 8 a.m. to 12 p.m. They have hand sanitizer and other things. If you really don't want to get out, then you can do it online. The online farmers market is still available. Thank you for watching this week's Ask the Doctors on Whitewater Community Television's WGTV Channel 11. We thank you for watching. We'll be back next week. As always, I wish you well. Have a good weekend.